Now we are going to start about the hypersensitivity types. Hypersensitivity type is the immune response that causes this. The immune responses that cause diseases. And they are exaggerated or inappropriate. They are exaggerated and inappropriate, and they can be allergic reactions, like that is a subtype of hypersensitivity. And if we talk about the hypersensitivity, is what is going to happen with the first contact with antigen. First, the body will contact with the antigen and it will sensitize. They will sensitize the immune response, and there will be generation of immune response by the antibody and the memory cell. But when that same antigen comes second time, then they will, the second time contact will go with hypersensitivity. Phenomena just like that. And the symptom from overreaction of immune system, and there is a fourth pattern of underlying immune response in the type 1, 2, 3 and 4. There are 4 types: anaphylactic and atopic type 1, antibody-mediated type 2, immune complexes type 3, and cell-mediated type 4. First we are going to talk about type 1. The type 1 is an immediate reaction to antigen, and it is in the minutes, and it can be happen by the pollen, pet, dendropinus, and they have the preformed IgE antibody that's a primary exposure. They're having preformed IgE antibodies that due to the primary exposure, the antibody bound to the mast cells, and these mast cells go into antigen bind and cross-links IgE and the mast cell degranulation. And they were susceptible intervene make IgE to antigens. The majority of people take IgG. IgG does not trigger the hypersensitivity response, but the IgE results from B cell class switching or driven from. Basically, what is going to happen? IgE, and it is coming to IgE by the class switching, and it is driven by hormonal response, and this is responsible by T helper 2 cells, helper cell 2. Who is doing this class switching? Helper cell 2, and I for interleukin 4 is a key cytokine for IgE production. It is a key cytokine for the IgE production. And guys, there is no complement. IgE does not activate by the complement system, as you guys know. In the type 1 symptoms, if we talk about the type 1 symptoms, then there will be skin, urticaria, hives. It could be respiratory tract infections like rhinitis, inflammation, wheezing or asthma. And secondly, there's the eyes, conjunctivitis or diarrhea, etc. There could be anaphylactic reaction like systematic type 1 hypersensitivity reactions, anaphylactic. They're having the itchy, diffuse hives, erythema, and the respiratory distress from the bronchoconstriction. And they're having the hoarseness, laryngeal swelling, edema, vomiting, cramps, diarrhea, shock and death, and a treatment in epinephrine. And also there is atopy. Atopy means there is a genetic predisposition to the localized hypersensitivity. And they are having the urticaria, rhinitis, asthma, and usually positive family history for similar reactions. And if you guys having the examples of a type 1, there will be asthma. There will be asthma, penicillin drug allergy, seasonal allergy, allergic rhinitis, allergic conjunctivitis, peanut allergy by the children, and cell fish like food allergy. And if we talk about the type 1 early symptom, it occurs within minutes. The symptoms are going to occur within minutes. By the degranulation of the mast cell, and they will going to release preformed mediators like histamine, and they will synthesize the release of leukotriene and prostaglandins and edema, redness and itching. And the lead symptoms are 6 hours later. And it is due to release of synthesis of cytokines. They having the influx of inflammatory cells like neutrophils and eosinophils. And secondly, it having the interaction. And if we talk about the type 1 mediated, and most common mediator is histamine. The histamine is the most common mediator, and they will cause a vasodilation, due to which you will form on that side, and it will increase permeability of venules. That will cause swelling. The swelling is due to increasing permeability of venules, and they are also having smooth muscle contraction that results in bronchospasm. The main functions are instrumental in the hypersensitivity one reaction. It will do vasodilation, increase in permeability of venules, and smooth muscle contraction that will result in bronchospasm. They are also having leukotrienes, prostaglandin, and thromboxane that are all derived from electronic acid. What? The leukotrienes, prostaglandins, and thromboxane. These all are going to be mediator of type 1. If you're going towards eicosanoids, just like that. Like this is a lipid cell membrane, and it was going to make arachidonic acid by the help of phospholipase A2. Okay, that arachidonic indeed will convert into leukotrienes, and they will convert into thromboxane, or prostaglandins. Arachidonic acid is going to convert into leukotrienes by the help of lipoxygenase, and arachidonic acid thromboxane or prostaglandin by the help of cyclooxygenase. This is the eicosanoids, and if we make the sample of a table of type 1 mediators like that we are doing, and we are making a table like prostaglandin E2, prostaglandin E2, prostaglandin D2, LTC4, and LTCD, and LTB4. Leukotrienes. C4, D4, and B4. What you guys know, the process can then going to do redness by the vasodilation, edema by increasing the permeability, and also fever by the acting on the hypothalamus, and second, pain by the nerves. And prostaglandin D3 will do the bronchoconstriction, eosinophilic infiltration, and leukotrienes are going to do vasodilation and bronchoconstriction. And also the leukotriene B4 is going to do neutrophil and eosinophil chemotaxis. That are mediators and their effect. We also having other mediators. The mediators are ECF A, like eosinophil chemotactic factor of anaphylaxis. Eosinophil chemotactic factor of anaphylaxis. They preformed in mast cells and they attract the eosinophils or the various stores. Also, we having the serotonin. They preformed in the mast cells and cause vasodilation. We're having the platelet activating factor and also doing bronchoconstriction. Also, we're having a neutral proteases. Neutral proteases like the chymase, tryptase. Also, we're having the heparin. They're the anticoagulant. These are other type 1 mediators. For testing for the type 1, testing for IgE, we will going to do puncture of skin or pinprick or puncture of skin. That will be also intradermal injection, transdermal injection, and if there will be a positive response, and there will be wheal formation. For example, this is the skin, but if it having a positive vacuum IgE, it will be like that. A wheal will formed on the skin. Understand? And for desensitization, what we are going to do? For this gradual administration of increasing amount of allergen or response change into the desensitization, you also do like that. For desensitization, we gradually do the administration of allergen by increasing the amount, and the response is going to change from IgE to IgG, so that the body becomes desensitized, and Antigen-antibody can block the mediated release and modify the T helper cell too. Let's start from the book, the type 1 hypersensitivity. Type 1 hypersensitivity, anaphylactic and atopic, they are having two phases. Immediate, intermediate, and late in the hours. Intermediates due to antigen crossing the preformed IgE on the pre-synthesized mast cells. They will go for immediate degranulation and release of histamine. And do a vasoactive amine and tryptase mark of the mast cell activation and leukotrienes. For the late hours, the reaction we're getting over sometimes that will by the chemokines attract the inflammatory cell and eosinophil due to cytokines. And other mediator from the mast cells, inflammation and tissue damage will be there. There will be two types, two phases, the immediate and late. The first type is the fast and anaphylactic. The first is a very fast, and for the test we will use a skin test by giving some intradermal injection, and which will be positive response and wheal formation is there. For blood cell, for the ELISA, for the allergen specific IgE, and the example are anaphylactic reaction, allergic asthma, like that. So the Razo diagram, they will allergen specific IgE antibody, allergen come and attach with it, and it will going for the FC receptor for IgE, and they will be degranulation of mast cells. Let's talk about the type 2 hypersensitivity reaction and type 2 hypersensitivity reaction. There will be antibodies. There will be antibodies, and these antibodies like IgG or IgM, and they're directly against tissue antigens. Against the tissue antigens. And they will binding to the normal structures. They are going to bind with normal structures. They are going to bind normal structure, and three mechanisms of tissue cell damage are there by the phagocytosis. There will be complement-mediated, like complement-mediated lysis, and thirdly having antibody-dependent cytotoxicity. There are three mechanisms for tissue and cell damage by the type 2 hypersensitivity. In phagocytosis, there will be Fc receptor. In phagocytosis, there will be Fc receptors or C3b receptors in phagocytes. In complement, there will be IgM or IgG that you go with the classical complement cascade. Classical complement cascade. Or there will be formation of MAC, and that MAC will go for the cell set. You guys know the complement system going to activate by the three pathways. That one was spontaneously, that called alternative pathway by the mannose binding lectin, and third was a classical pathway. And third, however, antibody-dependent cytotoxicity. They are having the antibody-dependent mediated cytotoxic, and they will use the natural killer cells. They will use natural killer cells. That natural killer cells are going to bind with Fc ligand of IgG. So they will active and cause a destruction. For the example of type 2, we are having the rheumatic fever, and they are having the strep antibodies that cross-react with the cardiac myocytes. Strep antibodies that is going to cross-react with cardiac myocytes. Then we are having next example, exposure to wrong blood type. And this is to the RBC lysis by circulating IgG. By circulating IgG, and they are having the erythroblast fetalis. If you guys know that, yes. Fetalis. And second is autoimmune hemolytic anemia. Hemolytic anemia. And due to many of drugs like methyl-dopa and penicillin. As penicillin. And second, these drugs bind to the surface of RBC and cause the damage and destruction of RBC by the system, and there is a mycoplasma pneumonia. Mycoplasma pneumonia. And that will also induce RBC antibodies. Further, we are also having some examples. That examples includes pemphigus vulgaris, mean there will be the antibody against the dismal forms in epidermis. Dismal forms in epidermis. And second, we have an example of Goodpasture syndrome. In Goodpasture syndrome, we are having nephritic. We are having nephritic syndrome and pulmonary hemorrhage. The Goodpasture syndrome includes nephrotic syndrome, pulmonary hemorrhage, and having the type 4 collagen. Yeah, also having type 4 collagen antibodies. Also, this example includes myasthenia gravis. There will be antibodies against acetylcholine receptors. These are some type 2 hypersensitivity examples that is antibody-mediated, or that is antibody-mediated. Let's read from here. The antibodies bind to the surface of the antigens like cellular matrices. It causes cellular destruction, inflammation, and cellular dysfunction. Cellular destruction, the cell is opsonized, coated by the antibody, leading to their phagocytosis or complement system active and natural killer killing by the antibody-dependent cellular cytotoxicity, which immunoglobulin involved for activity of natural killer IgG. Inflammation, there will be binding of antibodies to cell surface, and there will activate after there will be activation of complement system and Fc receptor-mediated inflammation. For the cellular dysfunction, the antibody bind to cell surface receptors that are going to make abnormal blockage or activation of downstream process. For that, we are also doing the direct COM test that will detect the antibody attached directly to the RBC surface. Because already we give one example of autoimmune hemolytic anemia. So in direct COM test, we can detect there is an antibody against RBC surface or not. In direct COM test, they detect the presence of unbounded antibodies in the serum. If the antibodies are attached to the RBC surface, then it will be direct COM test. If they are unbound antibody in the same, then it will be indirect COM test. And they are having the example already done, the autoimmune hemolytic anemia. Mostly it includes drug-induced with drug methyl-dope and penicillin, immune thrombocytopenia, transfusion reactions, and they are also hemolytic disease of newborn. Some examples also Goodpasture syndrome that includes nephritic syndrome, pulmonary hemorrhage, having the type 4 collagen antibodies, rheumatic fever, the step antibody crossing with cardiac myocytes, hyperacute transplant rejection also in type 2 hypersensitivity. Examples are myasthenia gravis. There will be antibodies against acetylcholine receptor, Graves' disease, and pemphigus vulgaris, in which there is antibody against dismal forms in epidermis. We talk about type 3. If you're going to talk about type 3 hypersensitivity reaction, then they are antigen-antibody complexes. Antigen plus antibody complex will form, and they will deposit in different structures, and they will activate complement. They will going to activate the complement system, and that cause the cell destruction. Generalized, there will be serum sickness, and localized. Generalized, there is serum sickness. If we talk about the localized, then it will be artist reaction. When we talk about the generalized type 3 about the serum sickness, there will be immune complexes in the plasma. I talk about the serum sickness or generalized type 3, then there will be immune complexes in plasma, and they will cause a systemic disease. And there is usually due to the IgG or IgM that are complement activated, and they deposit in various tissues like skin, kidneys, and joints. And they will going to trigger the immune response into the activation of complement and activation of macrophage and neutrophils by the Fc receptor. And also is having the historical description like a horse plasma used for the passive immunization. And inevitable 5 to 10 days later, there will be a trigate of the fever, rash, and atresia. To do the antibodies or horse serum antigens that are going to deposit in the skin and joints. What was happened in the previous time? They were giving a history of passive immunization. What is passive immunization? We are giving a pre-formed antibody to a human being. There were one person taken horse antibodies. After some days, he is giving after 5 to 10 days symptoms of fever, rash, or actually and the pain of joint. And is it due to happen? Because that antibodies of the serum going to join with the serum antigens, and they will going to deposit in skin and joint. And they're having like urticaria, purpura, low serum complement levels, low level of complement in the body, because all the complement going to active and start depositing. There will be purpura, elevated sedimentation rate, there is diffuse lymphadenopathy, lymphadenopathy, there is acute glomerulonephritis. And the classing same sickness, the rabies or tetanus antitoxin, and they can be caused by the penicillin. The same sickness is going to be classically by rabies, tetanus antitoxin, also rarely by the penicillin. Drug acid happening in monoclonal antibodies. Monoclonal antibodies like rituximab and infliximab. Another type 3 diseases are post-strep refractory systematic lupus, or there is a polyarthritis nodosa. And if we talk about the localized arthritis reaction, it's a local tissue reaction usually in the skin due to injection of an antigen. The preformed antibody in the plasma and tissue, they form immune complexes. And that local immune complex forms 4 to 10 hours after the reaction. And they will contrast with the type 1 in minutes. Like, it seems like that you are giving the antigen and they will be forming the immune complexes. But you can differentiate the type 3 with the type 1 if it's the localized type 3 by the time. The type 1 is giving the action within minutes, but arthritis is giving action after the 4 to 10 hours. And they are having the complement activation and edema and necrosis. If you are doing the immunofluorescence training, there will be antibodies complementing reservoirs. And they will be reported with skin injections like tetanus, diphtheria, hepatitis B vaccine, and insulin. And there will be swelling, redness is 5 hours after the injection. If you guys know about the hypersensitivity, pneumonitis, it is also called the farmer's lung. Farmer's lungs. And they are due to hypersensitivity reaction to environmental antigens. Now we are going to study from the book the part of type 3 antigens. For this, the immune complex antigen body, mostly IgG, and complexes activate a complement which attracts a neutrophil. Neutrophil releases the lysosomal enzymes and can be associated with vasculitis and systematic manifestation. Already they given the same sickness and arthritis. The same sickness is a systemic. This is a localized. In the prototypic immune complexes, the antibodies of the foreign protein are produced in the 1 to 2 weeks later. Antibody-antigen complexes form and deposit in the tissues that the complement activations, and they cause inflammation and tissue damage, in which there will be decrease in serum complement because all the complement are going to activate and making complex, and they are going to deposit. And for the arthritis reaction occur local subacute immune complex-mediated hypersensitivity reaction. It's an intradermal injection of antigen into the pre-sensitized and circulating IgG, and individual lead to immune complex formation in the skin. It is due to giving the vaccination or skin injection like tetanus, diphtheria, hepatitis B vaccine, insulin. And if you guys notice, on the same site of the injection, after giving injection, there will be swelling or redness. And this is happen to the enhanced local reaction to booster vaccinations. And they are characterized by the edema, febrile necrosis, and activation complement. In type 3 reaction, imagine an immune complex as a 3 things stuck together: antigen, antibody, and complement. Don't forget, this is a good mnemonic. In type 3, there will 3 things going to stick together, and they are doing nothing, just going to deposit in different surfaces of the body, that is antigen, antibody, and complement. We are having the example of SLE, reactive arthritis, polyarthritis nodosa, post-streptococcal pulmonary and IgA nephritis. Fever, urticaria, arthralgia, proteinuria, lymphadenopathy occur 1 to 2 weeks after antigen exposure. And same sickness-like reactions are associated with some drugs, may act as a hapten like penicillin and monoclonal antibodies. On ready we guys discuss like rituximab or infliximab. And it's also due to some infection like hepatitis B. Also, they did not mention about the antitoxins of tetanus and rabies. Now we are going to talk about type 4. The type 4 hypersensitivity is a delayed type. Reading the eventing, they are delayed side hypersensitivity, and they have a cell-mediated reaction. Having the cell-mediated reaction. Is a no antibody different from 1, 2, 3. Memory T cells initiate, and in that there is a memory T cells going to initiate the immune response. What is when there is a classical example of PPD test of tuberculosis, in which there are tuberculin protein injected into skin, like a Mentox test, like tuberculin protein are going to inject into skin, and that previously exposed person had the memory T cell, and the CD4 T cell recognize the protein. T cell recognize the proteins on antigen presenting cells, MSC class 2, and there T helper 1 response, and by this the T1 helper cell will be activated, and they and then it will be released interferon gamma, and it will going to activate macrophages. And after that, the interleukin 12 from the macrophages stimulate the helper cell 1 as a response, and that will result in the redness in duration to 24 to 72 hours later. It is after injecting of tuberculin, 24 to 72 hours later it will be happen. And how it is going to happen? The tuberculin is detected by CD4 T cell by the antigen presenting cell MSC class 2. They will give the response to T helper cell 1. They will activate it and they will release interferon gamma. The interferon gamma will activate the macrophages, and that activating macrophages will release interleukin 12, and they will stimulate the helper cell 1 responses to more release interferon gamma, and by that macrophages become activates. And now they are having an example the immune response to many pathogens like mycobacterium and also fungi, and they are having the contact dermatitis like chemical oil attached to skin cells involve CD8 cells that attack the skin cell, erythema, itching, and 12 to 40 years after the exposure. And if you contrast with type 1, also in type 4 example, we have a multiple sclerosis in which there is a myelin basic protein. Let's study from here in type 4 hypersensitivity. These are antigen presenting cells that presenting the antigen and synthesize the type 1 cells that release cytokines, raise interferon gamma, and activate the macrophages, and they will release interleukin 12. There are two mechanisms, each involving T cell. Direct T cell cytotoxicity that will happen by CD8. Cytotoxic T cell that will kill the targeted cells, like we already know about. They will cause the erythema, the itching by the contact dermatitis, the chemical attached to skin cells like oils and etc. And second, the inflammatory reaction that affect the CD4 cells recognize the antigen and release inflammation-inducing cytokine shown on this diagram. Already you guys know. And these responses that not involve antibodies, as the antibodies are using in type 1, 2, and 3. The examples are contact dermatitis like poison ivy, nickel allergy, drug reaction with eosinophilia, and systematic symptoms like stress. This is name of this like drug reaction with eosinophilia and systematic symptoms. Graft versus host disease. We also done with that test, PPD for tuber infection with the PAT test for the contact dermatitis, candida skin test for the T cell, immune for kindling. All tests are following the type 4 hypersensitivity rejections. Therefore, T cell transfer rejection, TB skin or touching. This is a mnemonic to remember as an example of type 4. And fourth is the last. So, they are giving a delayed response. As you guys know, in one you are getting a response within minutes. In second, you are also getting some hours. And 3 also in 8 to 12 hours or 1 2 weeks, seem like that. In type 4, you are getting delayed type after many 2 to 3 days. In 12 to 48 hours after exposure, they are going to start these type of redness, itching, and erythema. This is all about the hypersensitivity.